But there was an event and that, but there was an event that led to him having a series of seizures and then a massive stroke. He was in a coma for the longest 3 days of my life. He then woke up with no long-term effects. This required him to be on monthly transfusions. Many years into his transfusions, we were approached with the opportunity to do a bone marrow transplant as a cure for sickle cell. The transfusions had benefited my son in many ways, but he was going to be on them for life. This was his opportunity to have a chance at a cure. So we decided to test our children to see if they were a match. The results were in. There was good news and there was bad news. The good news was 2 of the siblings that were a carrier were a match. The bad news was neither of them were a match for my son on transfusions. So now we had a decision to make. My oldest was eligible for the transplant, but he was not very compliant at all. And this treatment required some serious compliance. But then we thought, he's graduating high school, the potential of moving away from home. What if he isn't compliant and gets sick and stays at home, which he would do? Is he going to be safe? He was all in for the transplant. He's a skydiving, bungee jumping kind of guy. And the risks were not even a factor for him at all. So we researched and we had many conversations with the doctors that we had grown to trust over the last 15 years through many visits to the hospital and treatments. And we decided to go ahead. Next slide, please. Preparations. As a precaution, we did bank my oldest son's sperm. My son that was a donor, he had to receive a series of injections to get his stem cells ready to be harvested. We don't live close to the hospital, so they did work with us to have somebody come to the house to give him some of the injections. So finally the day came and the donor child came into the hospital. They harvested the cells. My oldest son had to do 1 session of radiation and a mild dose of chemo. He did not experience any of the severe symptoms that they told us about, really only the mild ones. And he did not lose his hair, although his volume did decrease. Then came the transplant. So we thought the transplant was going to be this epic moment. My son and I were like, that's it. This looks like a transfusion with some funny stuff in the bag. And then the nurse laughs and she said, yes, this is it. Later, my son confessed that he thought that they were lying and were really going to drill into his bone, even though they repeatedly told him that was not going to happen. I'm like, who sneaks up on somebody and drills into their bone? He gave me a look like, it's possible. And we both laughed. After the transplant, everything had to be super, super clean. Daily changes of bed sheets, sterilizing of surfaces, no sitting food or drinks. We were all over it. We were all over it. We were only in the hospital for about 10 days before they told us that his results were good enough for him to go home. And we had actually expected to stay inside the hospital for a month, so that was really awesome. So we went home on a series of medications and we came back in for regular checkups, and each result came back yielding positive results. The treatment had worked. He was doing well. At the 1 year mark, he was only left on 1 medication. And then we were later given a vaccination schedule to revaccinate him because the transplant had wiped him clean. He's now at the 3 year mark and still remains a carrier only. Next slide, please. Thoughts from my children. I asked my children their thoughts on the bone marrow transplant. And so I'll start with my other children. So one of my children said that after the transplant, he was more loving to me. There was always this underlying tone between my children that have sickle cell versus the non-sickle cell kids. The non-sickle cell children would say, it's not fair. They get a day off school, they're going to the hospital, they get takeout. I want to go to the hospital too. And then my sickle cell children would reply, I don't know if I call getting stabbed. And yes, this is how my children refer to needles. Getting stabbed is a day off. Please go take the stabbing. I will go to school. But somehow, with the non-sickle cell going in to donate in the hospital, that changed everything. My son that did the donating said, I got a week off school. When I was in the hospital, I got to watch Harry Potter movies, so it was all good. Typical teenager attitude. He's too precious. And then my son that had the transplant said, overall, if he had to decide to do it again, he would. Radiation for him, although it was mild, was the worst part for him. He was tired, weak, had some mild pain, vomiting, and light sensitivity. And key point for him, I could not go on my phone. This was his priorities in that moment. Pros, overall, what he kept repeating to me is, I feel free. There were a lot of limitations that his sickle cell had presented for him. And after the treatment, he just felt free. Next slide, please. My thoughts. My journey with my children and sickle cell is now approaching 20 years. As I look back on the moments of learning and growth as an individual and family, we're grateful for the position that we are in. Prior to the transplant, my son that had donated to my oldest son, the two of them, while they loved each other, were not that close. They drove each other crazy because their personalities are very, very similar. The week that we came home from the hospital, that all changed. My children are all very loving towards each other. I mean, if you touch one, you're going to feel the force of all of them. But the bond that grew between my oldest son that got the transplant and my son that was the donor was something that was truly special and touching to me as a parent. My oldest son, prior to the transplant, if you had asked me to describe him, I would have definitely said that he was happy and playful. But since the transplant, there is a joy that he exudes that is unexplainable. And for that, we are truly grateful for the advancements of science and technology. Thank you so much for your time. And that's all for me.
Thank you, Fazola. Really, really great to hear that your children have had a positive experience through that, and looking forward to the discussion after our last presenter. I'm sure there'll be many, many questions for you, but thank you again. Our next presenter is Dr. Gaurav Karia. Dr. Gaurav Karia is a hematologist in Gurgaon, India, with over 17 years of experience. He trained at Netaji Subhash Chandra Bose Medical College, Baba Raghav Das Medical College, and has worked as a fellow in pediatric hematoma oncology, immunology, and bone marrow transplant at the Great North Children's Hospital, Newcastle upon Tyne in the UK. He is credited for doing the first haploidentical bone marrow transplant for sickle cell disease in India. Dr. Karia is also famed for doing in vitro TCR alpha beta CD19 depleted haploidentical bone marrow transplant in a 4-month-old baby suffering from severe combined immunodeficiency, which is the smallest child transplanted in the country so far. Dr. Karia, along with his team, have performed more than 600 bone marrow transplants. So Dr. Karia, we're looking forward to hearing your presentation, and thank you for sharing your slides. And just a reminder for the audience, please put your questions in the Q&A box, and we can start to, let's say, aggregate them in preparation for the Q&A session at the end of the session. Thank you very much. Dr. Karia.
Thank you, Sanjeev, for this generous introduction, and thank you, Sickle Cell Awareness Group of Ontario, for having me here for today's session. And definitely, this is something which I've been closely associated with for past almost a decade. So I would love to share my experience of what we have been able to do with respect to curative options in sickle cell disease in India. So I'll be taking you through curative options for sickle cell disease, what has been our experience in India so far. So I have no financial disclosures to make with respect to this presentation. Brief background about sickle cell disease. I think we all know about it. It remains associated with high risk of morbidity and mortality. Even the best possible supportive care fails to improve quality of life considerably, especially in resource-limited setting. Awaiting gene therapy, hematopoietic stem cell transplant is the only curative option for selected group of patients who continue to worsen on optimal supportive care. So here I'll be sharing our experience of bringing up a transplant program over past 8 years. The overview of today's presentation will be, I'll share our experience of initiating a bone marrow transplant program dedicatedly focused on sickle cell disease, how we built it up, evolution of protocols for haploidentical family donor, because that was something which was grossly missing, and the outcomes were suboptimal. When we started our program, our outcomes were also suboptimal. So that was our main focus. Then evolution of protocols for HLA identical donors, how sort of we have replicated the protocols from haploidentical family donors to HLA identical donor settings now. I'll briefly take you through what we have been able to do so far with respect to genome editing. And then finally, I'll summarize and move on to the question answer session, which we will take at the end of the presentations. So my journey of transplants for sickle cell disease. So as soon as I came back from Newcastle, as Sanjeev highlighted, so I finished my transplant training from Newcastle and subsequently from St. Mary's. And that was the place where I got sort of oriented to transplant and sickle cell disease, because as you might be aware, that's one of the center of excellence, and Josu was my mentor there. So after coming back from UK, I happened to treat my first patient, which was sometime in April 2014. And this was a match HLA identical sibling. This child sort of had a acute chest syndrome in the middle of a transplant, and we had to do the entire transplant on a non-invasive ventilation. But he's almost sort of 7 years, 8 years post-transplant and doing extremely, extremely well in life. Later that year, we got the opportunity of doing our first haploidentical donor bone marrow transplant for sickle cell disease. Again, this was a patient from African descent, from Nigeria, quite a symptomatic child. So we used father as a donor, and this child also fortunately did very well, and is almost again 7 to 8 years post bone marrow transplant, doing extremely, extremely well in life. So first of all, I'll take you through our journey of haploidentical donor transplants, because this was our main focus, because the outcomes were not optimal, and the challenges are quite a lot, especially in our settings. So just like any other trainee who comes back to the country and starts working, I also did the same thing. So when I moved back to India, I sort of tried to replicate the protocols which we were using at St. Mary's. And this was the protocol which we were using there for haploidentical donor bone marrow transplant. So there used to be this pre-transplant sort of immune suppression strategy with hydroxycarbamide and azathioprine. And subsequently, there was intensification of the conditioning using thiatepa. So this was sort of a modified Johns Hopkins approach or Bolognese approach, which we are using at St. Mary's Hospital. So this was the first thing which I implemented. This worked sort of okay, but it was not as good as I used to see while transplanting the patients in Europe. And when I sort of sat back and looked at the background of these patients, I realized that these patients are very different, and we need to modify our strategy to treat such patients. So this was the background of our second modification. It was based on the paper by Anuradha Panetel, where they used sort of an intensified pre-transplant strategy for patients with beta thalassemia major, and also a brief series by N.B. Paulowska, where they sort of use the same strategy in sickle cell disease. So we tried to incorporate fludarabine and dexamethasone as sort of intensified pre-transplant strategy, and treated few more patients for haploidentical bone marrow transplant for sickle cell disease. So we gave 2 cycles of Fludex. Conditioning was fludarabine, cyclophosphamide, TBI, thiatepa, which is sort of a standard kind of a thing used at number of places. GVHD prophylaxis was with PTCY, tacrolimus, and mycophenolate mofetil. So we treated 12 patients, but out of these 12, 2 had graft failure, 1 primary, 1 secondary, 2 had acute graft versus host disease grade 2 to 4, and 4 had chronic graft versus host disease, all limited. So, and there were, apart from that, there were some associated problems with calcineurin inhibitors, tacrolimus, which we were facing. So the aims of the third modification which we made were that we need to minimize the graft failure. For that, we focused on further intensification of pre-transplant strategy. We need to minimize the risk of graft versus host disease. So for that, we thought that probably plerixafor might help us in sort of getting preferential surge of CD34 and on sort of contamination of our graft by CD3 cells, and overall objective was to improve the overall survival and event-free survival. So the background of our third modification was based on these two papers by one of our colleague Bhatt et al. From down south in India. So they used the intensified PTIS, included cyclophosphamide for their cohort of patients with beta thalassemia major, and showed sort of exciting results. And the second one, role of use of plerixafor, was based on this paper by Rotella et al., which showed that by adding plerixafor to the mobilization, we can sort of modify the graft in preferable way, which it reduces the risk of graft failure and also reduces the risk of graft versus host disease. And we moved from tacrolimus to sirolimus to minimize the complications associated with CNI. So this was the protocol which we came up with, which was called as the Polo protocol. And subsequently, we published a series of 25 patients in 2020 December. And this was sort of the demographics of the patients. So median age was 7.5 years, range from 2 to 22 years. All had sickle-related complications, were non-responsive to hydroxyurea. 21 had mother as donor, 2 father, 2 sibling. All were DSA negative. All patients received a dose of cutoff CD34 dose of 10 million cells per kg, which was the standard in our protocols. Median CD3 dose was 16.53 into 10 raised to the power 7. So we can see that all these patients engrafted pretty robust at day 13, and the neutrophil and platelet engraftment both were at day 13. So very robust engraftment. Complications, all our patients had this typical haploidentical fever, which is seen after the haploidentical transplant. A number of our patients, almost 2/3 of our patients, experienced peri-engraftment fever or engraftment syndrome, predominantly the engraftment fever. CMV reactivation was seen in almost 40–45% of the patients, and few patients had this PK-induced hemorrhagic cystitis. Acute GVHD was seen around 20%. Chronic GVHD was seen around 3 patients. 3 had chronic sort of limited chronic GVHD. Chimerism analysis, all patients, alive patients, 22 alive, more than 95% of chimerism at the last follow-up. So at around 485, so this was I think some time back. Now this follow-up has been extended. So the overall survival and event-free survival was around 88%. So this we can see. So the overall survival and event-free survival was around 88%. Acute GVHD and chronic GVHD, both were less than 20%. So moving on to our further experience of altogether, now we have transplanted around 114 patients in past 7 to 8 years with sickle cell disease. So so we are in the process of sort of finalizing this manuscript. So if we just go through the breakup of these patients out of these 114 patients, this is the breakup. So HLA identical donor transplant, 54 have underwent HLA identical donor transplant, 60 haploidentical donor transplant. If we look at the breakup of the conditioning, almost 29 received Bucy-ATG. If you received thiotepa, trisulfan, fludarabine. This is our standard conditioning now, which is thiotepa, fludarabine, cyclophosphamide, Preplan, which is sort of augmented John Hopkins approach. So this is what we are using currently. In haploidentical donor transplant, again, there was a cohort with Thai, Flucy, Thymoglobulin, but nowadays we have moved on to Grapholon. So this is our standard sort of a conditioning, which is almost similar in HLA identical and haploidentical in the current protocol which we are using. As far as the GVHD concerned, majority of our patients received in the HLA identical cohort received cyclosporin and methotrexate, but we have moved on now to our post-transplant site strategy, and now all our protocols are PTCY based. So this is our sort of standard GVHD prophylaxis, which is PTCY, sirolimus, and MMF. Graft source, majority of these patients underwent peripheral blood harvest, they received peripheral blood stem cells. This is a breakup of pre-transplant immune suppression strategy. So as I highlighted earlier, we have evolved with respect to this pre-transplant strategy. So initially we just used hydroxyurea, hypertransfusion and hydroxyurea. Then we moved on to hydroxyurea, azathioprine, hypertransfusion, then subsequently to Fludex, then Flucydex. So this is how we have evolved in the pre-transplant strategies. If we look at the breakup of the neutrophil and platelet engraftment of this cohort of 114 patients, very robust. Again, 13 days median time to neutrophil and platelet engraftment. Acute GVHD rates have been acceptable. Grade 3, grade 4 GVHD was there in less than 10%. But if you look at the breakup, so obviously it was less in the HLA identical cohort, which was close to around 5 to 7%, and HLA haploidentical cohort, it was around 12% or so. Overall survival is around 84.5%. But if you look at the breakup of this, then in HLA identical donor, it is approximately 92%. In haploidentical donor cohort, it is touching around 80% or so. If you look at the overall survival and rejection and breakup into this HLA identical versus haploidentical family donors, so in matched sibling donor groups, almost 91% patients had survival beyond 1104 days, whereas in haploidentical donor cohort, it was around 70, as I said, it was touching around 80% or so. Looking at the chronic GVHD rates are around 18%, but majority of these patients have limited chronic. These 114 patients had extensive chronic GVHD. This is again the breakup, so quite obvious. HLA identical donor cohort, the chances, the rates of chronic GVHD are comparatively less, and it is relatively more in HLA haploidentical family donor transplants. So this has made us think that definitely one size doesn't fit all, and quite a number of times we had to modify a strategy based on the needs of the patients in present times. Moving beyond transplants, so why do we need anything beyond transplants? So even after all the advances in conditioning and supportive care, still there is high morbidity and mortality associated with transplant. There is limited donor pool. Age is a barrier. So obviously we'll not be very comfortable transplanting patients more than 15 years of age. There is risk of rejection, graft-versus-host disease, and obviously immune suppression related infections are there. So this definitely makes us think about more safer strategies, and that's why this gene therapy or genome editing comes in picture. So I'm sure a number of audience might have heard of it. I'll just brief you about it. I am sure my other colleagues who are in the panel they'll be talking about more about these gene therapy or genome editing approaches, but this is sort of a rough layout of how does it work. So if we have a patient who's suffering from beta thalassemia or sickle cell disease, that patient is harvested, the stem cells are taken out, and then they go through either mediated gene editing or lentiviral based gene therapy transduction, and then subsequently this gene corrected cells are then returned to the patient after giving some form of chemotherapy, and then subsequently they are allowed to grow back. So this is sort of an autologous transplant, we can say. These are the various groups which are working in genome editing. Please pardon me, I might have missed some of them, but the predominant ones are Bluebird Bio and CRISPR Therapeutics. In India, there are two groups which are working on genome editing. One is InStem, another one is Cellular Therapeutics, with which we work very closely. This is what we have achieved so far with respect to our genome editing work. So we have successfully documented this genome editing in model cell lines, and also in cryopreserved autologous backup of human cell lines, both for beta thalassemia and sickle cell disease patients. And subsequently, we are about to start our in vivo work in maybe in 2 to 3 weeks time. And subsequently, once it is done, we will be moving on to our formal human clinical trial. So to conclude my session, SCD is a preventable disease. As soon as the diagnosis is made, which is usually in the first year of life, supportive treatment should be initiated as soon as possible. A close observation is required to identify severe phenotypes. BMT should be offered to these severe phenotypes as soon as possible to offer the best survival and best sort of overall event-free survival. And as we make BMT more amenable to the masses, we should also prepare ourselves for future modalities such as gene therapy and genome editing. Thank you very much.
Thank you, Dr. Kara. That was a great insight into what you and your team have been doing in India. Y'all are pretty ahead of the game than us over here in Canada. And it's great to hear that you guys have made a lot of progress. 600 transplants is a lot, which is great. Next up, we have Dr. Rafaela Kolombati. A familiar face, great human being. She's done a lot in multiple continents. She's a hematologist at the Department of Women's and Children's Health and University in Padova in Italy. She's also in charge of the hematology anemia clinic, has been involved in many sickle cell research studies, cerebral and neurocognitive abnormalities and brain functions studies as well, and has also participated in programs and efforts in West Africa dealing with hematology and infectious disorders. So take it away, Doc.
Thank you very much. Thank you for inviting me to share some time with you and for the kind introduction. So we are part of this session, Curative Treatments for Sickle Cell Disease. And I've been asked to present a bit of the European experience in curative therapies and also quality of life. I prefer to entitle my presentation Tips from European Experiences, of course, because I'm going to share some concept with you today. And these are my disclosures. So we are in a new era for sickle cell disease. Started a few years ago. We have many more treatment options than before. And so what, as physicians and our patient groups in Europe, we felt a few years ago was that we needed to start a journey that had to be a journey that we made together, patients and physicians. And one example of this was the annual patient-physicians meeting that we organized since 2019. And we asked ourselves together, what do patients want? What do people with sickle cell disease believe as the most important topics to address or issues to resolve in clinical care, but also in research? And this was the topic of one of the first meetings that was also presented at the EHA a few years ago. And there were top 10 research topics that the patient representative from many European countries, but also from abroad, outside Europe. There were more than 45 patients involved in this work. And I want you to focus the attention on the first two answers that the patient gave. We want a universally available cure for sickle cell disease. So not just feeling better, but a cure. And we want to improve quality of life for people living with sickle cell disease. And at that time, and we still don't have the answer, but these were two paths that we thought we had to move and work together. And if we consider another global research, these are data from the SWAY international survey that involved more than 2,500 patients in more than 15 countries across ages. You can see that improving quality of life was ranked as the most important treatment goal across all age groups. So it was a goal for children, teenagers, preteens, young adults, and beyond. So everybody wanted to improve quality of life, to feel better. And so when we talk about cure, what do we mean for cure now, in these days? And if somebody of you had a chance to be at ASCAT a few weeks ago, there was a fantastic debate on what is cure and what is considered to cure a person with sickle cell disease. Is it a drug? Can a drug be considered curative? Is it transplant? Is it gene therapy? So we can discuss, of course, but it depends also on the symptoms and on the manifestation of the disease. For somebody, cure might be not having any more vaso-occlusive crisis. For others, might be not having any more hemolytic anemia. For others, might be not having progressive organ damage and maintain the function of the organs. For others, it might be maintain fertility, or having a satisfactory social professional integration. Or for others might be avoiding any risk of cancer. And I thank my colleague Marco Zecca, who prepared this slide. In spring, we did several webinars in the Italian Association of Pediatric Hematology Oncology reviewing the standard treatments as hydroxyurea transfusion, bone marrow transplantation, because we felt we needed to look at them from another perspective. And then we have to consider that curative options like bone marrow transplantation have benefits, have limitations, and have risks. Of course, the benefits is that when donor chimerism is above 20%, for example, you don't have anemia, you don't have hemolysis, and you don't have vaso-occlusive crisis. And there is evidence of stabilization or improvement of organ function in many organs, spleen, lungs, cerebral vasculopathies. But there are also limitations. Of course, you don't have, and not all patients have a HLA identical donor. And many times, since patients belong to minorities, we don't find a donor. But many patients have an haploidentical donor, so that can be considered an option. But there are also risks. And we heard from the first presentation that risks are usually explained a lot to patients because we have to have a thoughtful decision. So graft versus host disease, rejection, impaired fertility, or increased risk of leukemia. So all these factors, benefits, limitations, and risk must be taken into consideration. And of course, we have to consider the improvement in quality of life. But as you can see from this recent review, very few information is available for quality of life after transplant in sickle cell disease. There were only 7 papers found in the literature for limited age range of patients, and the majority coming from the US, all of them. So there is lack of information from other parts of the world. Does bone marrow transplant really improve quality of life? Is it worth it? We need a lot more joint work to demonstrate that curative treatments improve quality of life. What about gene therapy? There are limited data yet, but encouraging. According to the scales that are used to evaluate quality of life. So gene therapy reduces pain, pain intensity, pain interference, anxiety, depression, satisfaction with social roles, fatigue, and physical function. So very promising, but again, limited. We need more information. We did a similar research in our center evaluating quality of life in before and after transplant. And as you can see from this slide, of course, there was no severe impairment in patients in those domains presented. But again, quality of life was not perfect in all the domains after the transplant. There was still some sleep disorders. There was a degree of chronic pain. There was some compromise in the physical abilities. Probably even the scales that we are using are not enough to evaluate what happens to an individual before and after transplant in the domains that can be ameliorated and those that will not benefit. So there was impairment, but not in all the domains. Another thing that we have to consider is when we talk about curative treatments, what do patients want? And probably patients have to ask themselves, and we have to dialogue together, because this is a recent topic. What does a person with sickle cell disease in that moment of their life prefer? There are many more choices than in the past. And these choices can be difficult, can be different, can have different benefits and risks. So as physicians, we need to sit down and discuss many times, and we heard it from the first presentation, but we also need to take into consideration patient preferences. And again, there are many experiences that are coming out, which is good, and more should be made in different settings and should be shared. And again, there is a decision-making process. that we need to establish in all our centers. Sometimes it's communicating is not easy between hematologists, transplant experts, patients, families, and we need to consider all the approaches and the attitudes in our settings. And again, the shared decision-making is changing due to the many options that we have. And there were two recently published nice educational sessions at ASH. Some people really don't want any other thing that being cured. Others maybe don't feel as understanding everything, but in the current times, we need to make the families aware of the realistic expectations and risk. But again, I need to sit down and make a really shared decision-making process that might take time, and in order to find the best solution for each patient. So the conclusions of my tips of European experiences presentation is that we are in a rapidly changing era for sickle cell disease curative treatments. And the meaning of cure and improvement in quality of life need to be discussed in depth among all experts and families. And shared decision-making is crucial. It takes time and effort, and a lot of research is needed in this setting, but is the key to finding the best treatment for everyone. And I want to finish my presentation with this wall painting that we made in our pediatric hematology oncology clinic last March. It represents 3 stories of 3 patients, and it represents the family burden of sickle cell disease as a genetic disease, a mother and child, that you can see also in the picture. The lightning that represents this vaso-occlusive crisis that disrupts suddenly the life of patients, but also the flowers as a sickle cell shape, that they said life can flourish and be nurtured in spite of the disease. So we need to talk more and raise awareness about this. And again, this is a joint journey, patients and physicians. Thank you.
Thank you, Dr. Colombati. Very inspiring. And I like the way you started this presentation with the fact that it's a new era in the evolution of treatment, but also that it has resulted in an evolution of shared decision-making as well, because those discussions can become, let's say, much more holistic, and where patients are also empowered to think about what are those factors of quality of life that are important, and how does that play into a shared, let's say, decision-making model. So thank you again for that presentation. Excellent. Our last speaker today is Dr. Donna Wall. Dr. Wall is currently leading the blood and marrow transplant cellular therapy section at Sick Kids University of Toronto. She's experienced in transplantation, gene therapy for treatment of cancer, immune and hematologic disorders. She is involved in CRISPR-mediated gene therapy trials for sickle cell anemia and thalassemia. Dr. Wall holds the Guerin Family Hats Off to Kids Chair in Childhood Leukemia Research. So Dr. Wall, pleased to have you here, and I will turn over to you.
Well, thank you very much. And please tell me if you have any trouble with the slides. What a true joy to be part of this panel. And I could keep talking for a long time. And you know, us academics, you know, we have a hard time with 10 minutes with short talks. But and the questions and issues that have been raised by my colleagues and the wonderful observations by the mother of a patient who went through transplant, it just generates so many questions. And I'm going to kind of play off of the observations that have already been raised, focusing on our evolving options towards offering curative therapy. I do work with companies involved with the development of the of gene therapies, and we are very thankful to a grant from the Thalassemia Foundation of Canada for an investigator-initiated trial to improve on the transplant for patients undergoing transplant for thalassemia. My role has been to provide technical support. I have no financial benefit. Everything that we've been talking about, all curative approaches to sickle cell anemia involve the hematopoietic stem cell, which is the is the part of our blood that gives us lifelong blood making. All treatments that are curative involve working with this very primitive component of the blood making system that not only makes red blood cells, and which is where the problem is with sickle cell, but also the parts of the blood that cause clotting, and our immune system, which basically is the system that says, this is me, this is not me. When we do our treatments, we are not smart enough to just say, I just want to fix the red cells here. We actually do a full swap out. Okay. And so that's a key concept in transplant. And it impacts the gene therapy strategies as well. But what that means is that when we do a transplant, we're replacing the immune system. And that's what my colleagues were talking about in needing to have cooperation between the new blood making system that goes in with the patient's own immune system. Otherwise, we get really bad immune problems, and that's the graft versus host disease that was alluded to. We have at our center, we have had a strong collaboration between our sickle cell thalassemia hematologists, as well as a transplant group, and have been working on a strategy saying, if we're going to do a transplant, we have to leave as low a footprint as possible. Because if at all possible, we want to avoid using high doses of chemotherapy. We don't want to bother the kidneys. We don't want to bother the liver. And so these are actually pretty tricky transplants for us to do. We participated in a international trial that takes that would developed off of observations from the folks at the NIH in the US, that you can do a transplant to, if I may, take the low and slow approach, okay? And the idea here is that we collect the young mother cells, or the stem cells. Before that, we quiet down the patient's immunity by using a drug called alemtuzumab. That's an antibody treatment that basically removes the circulating immune cells for a time period. And we give one low-ish dose of total body irradiation. And I'm not a radiation fan, but this tool, at this dose, we should not be bothering fertility. We attempt also to protect fertility with gonadal shielding. And then after the kids, and then a day later, we give those young blood making cells, as Fazola had told us, just as a simple blood transfusion. The trick here is that we use an immune quieting drug called sirolimus for a long time period. We go for a year or 2 years. What happens in that time period is the new blood making system that grows up will gradually replace the immune system over time, rather than all at once. Here I'm showing you the early results from the SUN trial, showing that with this very gentle strategy, we have minimal use of blood products compared to a more standard transplant. And the kids have been able to get out of hospital very early. The main risk for this type of transplant is graft rejection. Overall, with this very gentle approach, we have satisfying responses, and with our big risk being about a 10% risk of rejecting the graft, which basically puts a patient back at having sickle cell anemia. As mentioned from the previous speaker, I'm so happy that we're now starting to talk about quality of life. Very satisfying, quality of life scores, both in comparing to what kids were pre-transplant to what they were after transplant. Most with a brief blip down during the heat of the transplant, and then coming up. And we actually have recognized recently for both the gene therapy and the transplant patients that we open up a huge, for me was completely unexpected, a series of new problems, because the kids and my young adults have a hard time adjusting to normal life and having new expectations and moving out of the role of a sick person to a healthy person. And so I think that's worthy of many more discussions. So our next steps, we have moved the transplants to include patients who have red blood cell group mismatching as well in the matched sibling setting, and so far so good. We've it's a little too early for me to be sharing those results, and we are now moving. Since we're doing so well with the matched sibling donors, we're moving into the half-matched donors, or the haploidentical donors, as was described in the previous talk. The other approach, the gene therapy approaches, are take a strategy that an appreciation that we at time of birth, there's a switch in the kinds of hemoglobins that we make, and adult hemoglobin has starts being produced just right before birth and then kicks up. And the mistake with sickle cell anemia is in this beta hemoglobin gene. What the strategy with the gene therapies is, well, wait a minute, what if we just coax patients to just make that fetal hemoglobin, the blood that they were making beforehand, this which is not affected by the sickle cell gene. And this is a strategy. This is the whole background behind us using hydroxyurea, which has been such a big game changer in the care of sickle cell anemia. We know that for patients with sickle cell anemia who just normally walking around have high amounts of fetal hemoglobin in their circulation, because there's this changes based on your family inheritance patterns, and there's some areas of the world where patients have just higher amounts of fetal hemoglobin, that those patients have a much milder course with their sickle cell anemia. So we had background information to support this making a difference. The gene therapy study that we've been involved with here is, as the previously mentioned, CRISPR-Vertex strategy. And the idea here is that we're using a enzyme treatment. So it's a one-time enzyme treatment that goes in and makes a cut, a deletion, right at a critical point in the part of a control gene called BCL11A that controls that switching from making fetal hemoglobin to deciding to make the adult form of hemoglobin. So we basically cut the switch, and with that, the patients will go on and just make fetal hemoglobin in the cells that are corrected. The machinery, the cutting agent that we use is the recently discovered and CRISPR CRISPR approach, where and the molecular biologists have done spectacular work in defining what gene, what is the genetic makeup of these different areas of the genome. And we can come in very specifically and say, excuse me, caspase, which is an enzyme, enzymes cut right here. Okay, and it's a very focused correction. It's an enzyme treatment. It's it's simplicity. You've seen this slide already. The points I want to make from my colleague is that the gene therapies are still, I'm going to use the word clunky, and yes, I did use the word clunky. They're our first generation of gene therapies. They still involve a lot of the steps that are involved in a bone marrow transplant. we have to collect those young blood making cells. So we, as you heard on the previous speaker, we use a growth factor, GCSF and plerixafor to get those young blood making cells into the bloodstream. In the laboratory, we isolate the young blood making cells. We do this enzyme editing. There's no viruses involved here, but these cells do get a fair amount of treatment in the laboratory, and then we freeze down the cells. Tons of testing is done. Patients ready for treatment. The treatment, guys, involves chemotherapy. So it looks just like a bone marrow transplant because we have to make space to get the cells in. Cells go in, just like Fazola had said, it just looks like a blood transfusion, and then they recover. I can't tell you how excited we are with our early results. Now, unfortunately, our big meetings are next month, and we're not allowed to release data until they're discussed at the meetings. But I'm going to tell you about the first 3 patients treated, and I'm telling you that for the next 30 plus patients who have received the treatment, and so it's only 30 patients, okay, that the results are holding. So this treatment, because of the chemotherapy we used, looks just like a bone marrow transplant. It takes a bit of skill to collect enough young blood making cells from a patient with sickle cell anemia, but we can do it. And the good news is that after treatment in all the patients treated so far, there's been no pain crises afterwards. The red cell breakdown, the hemolysis, the kids who had the sort of yellow eyes and running problems with chronic breakdown of red cells has cleared. Hemoglobins are, so you have to add, in Canada, you have to add another digit, so are between around 120 gram per liter. So the patients are feeling much better, no longer being anemic. Importantly, we're showing that with this correction and now falling out to 2 and 3 years, and this is in thalassemia patients and in sickle cell patients, and there's more data. I can't show you the detailed data here. The correction has been stable. So we have been able to target those very youngest of the stem cells and get the correction in. So needless to say, we're incredibly excited. But I have to just tell you, this is a big deal and it's not easy treatment, and we're not there yet. There is a concern raised in the gene therapy world of the risk of developing leukemia in treated patients. And there have been 2 patients who at this publication, out of 47 treated, who did develop pre-leukemia or leukemia. There's been intensive work to try and sort this out. There's no evidence that the virus that's used to get the corrected gene correction used in some of the other approaches was causative. It looks like there's just a higher baseline risk of leukemia and pre-leukemia changes in patients with sickle cell anemia, not made worse by hydroxyurea. And it basically goes to the fact that the chronic inflammation and the fact that red cell production is always on, go fast mode through your whole life, that this is increasing the risk for a mistake happening. So this is something that's being followed very closely. And importantly, the treatment here, the observation is that for patients who have developed leukemia after transplant, it's not been in the transplanted cells. It's been in the patients who've rejected the graft and have had poor blood making. None of the patients who are fully engrafted after bone marrow transplant have developed leukemia. So we're piecing the story together, but it's just full disclosure that this is an issue. There are about 3-4 different strategies for gene therapy that are being tested right now. I told you about the one that increases fetal hemoglobin production. There are other strategies where they use a virus to get genetic material into those young blood making cells and either cause a cut in them the same way I described, or else put in a little bit of normal hemoglobin, and that's what happens with the Bluebird Bio gene product that is moving through the clinical as well. All of them use the same strategy of collect the young blood making cells, work with them in the laboratory, give the high dose chemotherapy, and then have the recovery period. So the key elements are all very similar. So far, the longest out is about 10-year follow-up, all very, very small numbers at this point. But importantly, to date, all the gene therapy strategies have decreased the amount of transfusion needs, cut vaso-occlusive crises and other sickle-related side effects, and we're not having iron-related issues. So I'd like to take whatever minute I have left here is to talk about when to offer this curative therapy, and I think this is where we really need to work together on here. And as alluded to the previous speakers, this is not easy. It involves a lot of education. You want to do the treatment before you have end organ damage, while things which may not be reversible. We currently offer personalized counseling sessions with patients and families. Thank you, COVID, for the Zoom meeting. And we sit down and we have a family fireside chat. And then we have worked very closely with our hematology colleagues. And as alluded to Dr. Colombati, this is not just a one-time consultation. We have many discussions going forward. So the gene therapies are coming. They're exciting. We're still very early days. We're making major improvements in bone marrow transplants. And now the next part of the journey is to know when, when to push the big red button, as I warmly tell my trainees. So with that, I'll hand things back to my colleagues.
Excellent.
Thank you, Dr. Paul. That was great and very informative. And thank you for the transparency with the good and the not so good. But yes, we have to work together on figuring out a way where we can all have people have access and know more information about it, to change the lives and the families of people dealing with sickle cell anemia. But thank you, all our presenters. This has been very informational. We're going to jump into some questions. So first up, Fasola, this is for you. When your son went through his journey with the transplant, was there any mental health counseling offered, or was that discussed at all?
So he did do some surveys where they did check-ins on him, but he didn't have to do any form of counseling. So I'm sure if his survey had been negative, they would have supported him in that nature, but he didn't do any counseling per se. He's very happy, like a glass full kind of a kid. So he took it like, oh, I'm going to get to the other side of it and it's going to be awesome.
That's good. That he has a bright personality and can weather that storm. And as Dr. Wall alluded to, like I'm sure for many people, that this type of change in their lives can be very dramatic.
Yes.
And hard to deal with, growing up or living with an illness such as sickle cell and learning all the ways to cope and manage with it and getting used to that. And then suddenly, like, you know, within a few months or a year, all of that changes. It must be a hard adjustment. I'm wondering with all our other panelists, if that mental health aspect is being discussed more or something that's being offered. Maybe
I can say something if you're asking. We had a national discussion on this together with the patients last spring, and I believe it's in our setting, it's not considered enough. Of course, there is a evaluation during the transplant, but what some of the patient, and again, this might depend on the needs of the individual, they complained about is what happens after 1 year, 2 years after, 3 years after, when you look at all your life that you lived, and maybe you have some consequences of the transplant that still remain. And this is not thoroughly thought or organized when a person is considered cured, but not cured of all the issues. So I believe this still has to be a great effort to organize better the post-transplant according to the needs, post-curative therapies according to the needs.
For sure. Thank you for touching on that. And Faisal, a quick question. How old was, if you don't mind, how old was your son when he did the transplant?
He was 17.
17. Okay.
Yeah.
Great.
That leads to another question, which is on the list. At what age is a transplant not advisable? Maybe Dr. Karia, I think you gave a response. Would be good, I think, for everybody to hear your advice on age for transplants.
Yeah, so basically, I mean, as a standard dictum, there's no age. So what decides the option of transplant is there is no transplant is the need of transplant. So if there is a need of transplant, you have to find a way to do it as safely as possible. So that's sort of one way of looking at it. But if you look at it from the statistical point of view, so out of 114 patients which we have transplanted, if we sort of categorize them, so we can definitely say that any patient who's beyond 13 or 15 years of age, the outcomes are not great. And if the patient is less than sort of 13 years of age, the outcomes, either it is a haploidentical family donor transplant or it's a HLA identical donor transplant, the outcomes are fairly good.
If I may, are you predominantly pediatric center?
So basically, all the centers here are sort of mixed centers. So okay. Yes, majority of our work is pediatric work. I would say around 90% of our patients are pediatric patients. But yes, we do get around 10% patients which are sort of young adolescents or young adults.
Yeah. So there is, I do know at Princess Margaret University Health Network, there's a strong adult movement or project development, for transplant for sickle cell disease, and so that might be good for a future discussion. And the gene therapy trials in general are open to about 35 years of age.
Excellent.
So one quick thing that I kind of want to touch on is that we've discussed two kind of routes to a cure, which is bone marrow transplant and gene therapy. If someone could quickly just summarize what the difference is, just together, and what the risk factors between the two, and the difference between accessibility.
I can take, because we do both. So if you have an immune matched sibling and the decisions to go to transplant, that would be the recommended pathway. Okay, so it's only when we don't have an immune matched sibling that we would start the discussion. Should we look at transplant or just continue with medical care, which is excellent. We can't forget that. Or look at the gene therapy. The gene therapy trials are all trials at this point, and they are recruiting patients who are really very sick. And so and then where this has been the most difficult part of my journey, finding somebody who is sick enough to be eligible and not too sick for the treatment. And it's tough. As we get better at it, we'll be able to offer it earlier and whatnot. But we're not there we're still in the early development stages. We have the first model. We're at the Model T, and I'd like a Camaro, please.
Thank you, Dr. Wall. One of the questions I thought was interesting and a little bit on a different angle. This is for Fazola. Have you noticed a substantial increase in the stamina of your children when they engage in physical activities after the transplant?
Yes, absolutely. I think he actually, while he was still in that phase where he was taking a lot of medications, and it was still like because when he had his transplant, it went right through when COVID started. He had no fear. He's like, oh yeah, I want to go to Florida. We're going to go to Disneyland. Calm down with the energy. But he was super excited. He couldn't wait to do everything because he had a lot more energy, and it showed in his face. Like he had a glow for sure.
Excellent. Great to hear. So, I know we're just getting to time. I think we have time maybe for 2 more questions. I'll ask this one, and I think this one was for Dr. Wall, because it popped up during your session. This is about, I believe, I read a research article around this in the New England Journal of Medicine. The results were very promising with a 12-month period. The article mentioned some adverse events of pneumonia, sepsis, abdominal pain. Have you observed these as well? And will there be modifications to the treatment to alleviate or reduce these events? I think you know the article.
Yeah, no, I know it's the Bluebird article. This is what I was trying to get at. We're doing a full transplant as part of the gene therapy. And so the patient's immunity does drop for a good length of time. And so these are the kind of risks that I'm used to accepting every day, but are new to somebody who just, but is living, with the chronic burdens of sickle cell anemia. That's the reason our strategy in our transplant approach with the SUN trial has been to go as gentle as we can. Keep that, because it's just hard. But we are actively working on it. So, and a big push on research is to not have to use the chemotherapy. Big push on research to not have to pull the cells out of the body to do the gene correction. We're at a very, and there are tons of really smart people working on in this area. What's happening right now is we've got the proof of principle. That we can do it. And I have to just big shout out to, I've spoken to close to 20 patients with sickle cell anemia for the gene therapy trial. Just their bravery, their insightfulness, their willingness to engage in this kind of treatment, where I've had to tell them, I have no clinical experience. I don't know if this is going to, work. I do know that I'll probably that you'll probably get sicker for a little while. But I have learned from both the thalassemia and the sickle cell patients is everybody needs counseling afterwards for anticipating that transition from being sick to not sick. This hit me because I was just looking as, you should be feeling great, doing good. And then they're really depressed. And, I said, I can't figure this out, but it does get better. And with good counseling, but now I anticipate, which is a big difference.
Excellent. Thank you, everybody. So I think we probably have time for one more question. This one is, a sickle cell patient that had a splenectomy can still be eligible for transplant.
Yeah.
Sorry, Dr. Karya, I didn't catch that.
Very well. I mean, that's not the criteria which we consider. So he or she can very well be considered for transplant.
Yeah.
Excellent.
Yes.
Great. Excellent. So I know we are very keen to also get to the next sessions, the third simultaneous set. So look, lots of progress in research and development, and I think this is a great to again rephrase the Dr. Columbadi's. It is certainly a great era for patients, caregivers, and those impacted by sickle cell. Really thankful to all of our physicians and industry partners and stakeholders who are focused on this space and really raising the voice for this devastating disease and everything that we can do to move it forward. With that, I'd like to thank all of our panelists, Dr. Wall, Dr. Columbadi, Dr. Karia, and our wonderful patient parent, Dr. Ms. Fizzola. So thank you all for making time and for your wonderful presentations. And also to my co-moderator, Gabrielle, who was fantastic in helping us moderate this session. So at this time, I'd like the next step would be to return back to the lobby and where the simultaneous sessions are there in terms of technological interventions, Canadian Blood Services, or the use of simulation educating healthcare professionals. So we look forward to seeing you in one of those 3 sessions. So with that, thank you everybody for this session and have a great rest of the day. Thank you.
Thank you, everybody.
Bye-bye.